Guys, we're only a couple of days away from Cabofest 2018. The URL is cabofest2018.com. One of the speakers that's going to be there, his name is Ben Smith. This guy holds a special place in my heart. He's actually one of the guys who taught me ultrasound. He was my ultrasound director when I was in residency. Here, we're going to show you the talk that he gave at Cabofest, which was just, maybe a month or two ago, where he talks about how echo can save lives.
Oh, man, I hate to admit it, but Jacob's right. This Ben guy knows his stuff. Ever since the first time I saw him give a cardiac ultrasound talk, I had to have him at every conference. It's going to be at Cabofest this year, so if you're going to be there, you'll see him there. If not, you should come check him out at BenFest. Check out benfest18.com. Jacob's going to be there, Ben's going to be there, Leanne's going to be there. It's going to be an awesome team. Come check it out. And now, Ben Smith.
If you're not good enough at ultrasound, that's not an excuse to punish your patients with radiation.
Get out there, ultrasound some hearts, some lungs, some IVCs. Let us know how you feel about it.
Yeah, we can definitely do that, or we could be better clinicians and use our ultrasound.
Thanks, Mike. I'm Ben Smith. I'm from the States, from Tennessee, the Southeast, and I'm actually really happy to be here because it's really cold in the Southeast. Although my wife told me actually, just as we left, that it was 60 degrees, so I just escaped the cold to come here. Anyway, so we're going to talk about basic echocardiography. And what I would say is that I love all ultrasound. Behold, the mighty ultrasound. And the curvilinear probe is good, but it's not going to save nearly as many lives as the phased array probe. And even Mona Lisa knew that, actually. And so what I would say is that you should really grasp onto that a phased array probe, and you will save lives. So I'm going to go through some cases to start here. So all three of these cases I had as an attending. All three of these cases presented very sick, hypotensive, very ill. In all three of these cases, the management dramatically changed because I had bedside echo in my armamentarium. So case one. This is a 45-year-old lady. She's got lupus. She comes in feeling short of breath and weak. Her pressure initially was 90 systolic. Gave her a little fluid bolus and sent her back to our workup area. The nurses called me about 20 minutes later, said she's gotten really altered and her pressure's dropped into the 60s. So I go to the bedside and she looks very ill. Case two. This 30-year-old male, it's actually a friend of one of the residents, comes in just sort of feeling short of breath and weak. His initial pressure is 90, and actually he dropped his pressure as well. He looks pale, just very poorly perfused appearing, dry, cracked lips. And his only history is he's smoked some weed in the past, but he had some a mild cough and fever the week before. His chest X-ray gets read by radiology as bilateral interstitial pneumonia. Chest and his blood pressure drops into the 70s. I'm thinking to myself, it makes no sense that this guy who's otherwise healthy would have essentially sepsis with bilateral pneumonia. Case three. This is my emergency department, and that room right there is room 17, and this is from my seat at my Epic workstation. And our Hamilton County EMS, which is our local county EMS, brings a patient in. They're kind of signaling me in there. They're come in here, this lady's really sick. So she's 40, and they put her from her gurney onto the bed, and she goes apneic immediately. EMS says she was with her teenage kids and felt short of breath, and then they called EMS because she passed out. So she goes apneic and pulseless. We do a round of CPR, one of epi, we get her back. She's tachycardic, 140. I turn to EMS and say, what's going on with this lady? And they're like, well, all we know is she twisted her ankle the week before. That's it. A minute later, she codes again. We get her intubated, 100% of 502. She's purple, still. She codes again. We get her back, one round of epi. We'll come back to all three of these cases. So basics on bedside echo. If you don't have one of these phased array probes on your machine, get one. This is the probe that's optimized for cardiac. So it's great frame rate, not the highest resolution probe, but it optimizes the frame rate because you're looking at a moving structure. So that's why this is the probe you need to be using. Had the patient supine or on their left side, can really improve your view, sort of bring that heart anterior. And a quick note about the dot here. You see the dot on the side of the screen here, dot on the side of the screen here. We're trying to get the same images that cardiology gets between these two images here, but I'm going to teach you how to orient the probe to get these cardiac views with the probe dot on the left side of the screen. All right. What cardiology does is 180 degrees. They flip the probe and they flip the image. That's just a standard. So sort of about 50-50 on the point-of-care ultrasound community on how they orient the wedge there. I'm going to teach you based off the left side of the screen, which is what most of our other modalities use. So some real basics. If you can't get a good view of the heart, it's usually not the gain button. Just keep your hands off the gain button. Use a lot of pressure, a lot of jelly, and that'll get you, and then sort of move around, try to find that window. Usually it's a matter of technique with your hand and not a problem with the machine. All right, we got 4 basic views. You should try to master each one of these views because on any given patient that you have in front of you, you may only get one adequate view. And so on any patient that I'm doing a bedside echo, I'll do the peristernal long, peristernal short, try to find a subxiphoid in an apical view. One may be much better than others. Each one has their various advantages we're going to go through now. So a peristernal long axis view of the heart, this is a fantastic view of the LV. So if you have somebody that's really sick in front of you and you want to see if they're in cardiogenic shock, this is the view you should try to go for. So a great view of the LV right here. LA, that makes that the mitral valve. And just above that, you have aortic valve and a little slice of the RV. It's called the right ventricular outflow tract. So to get this second intercostal space, probe marker towards the left hip. And here's the view you get. So this is a great ejection fraction. You can see this mitral slap is great. The anterior mitral valve is going and touching the septum. E-point septal separation, that's the technical words, or EPSS. And if that anterior mitral leaflet comes within 7 millimeters of that septum, the ejection fraction is normal. That's a surrogate marker for ejection fraction. Peristernal short, exact same place, and twist the probe 90 degrees clockwise. All right? This is sort of the donut view of the LV, the base of the papillaries, and a little bit of the RV. The important things to look for are that this is nice and round, that this interventricular septum sort of bows into the RV instead of the other way around. When that flattens out, you actually end up getting a D-shaped LV, and that suggests high right-sided pressures. So again, second intercostal space, probe marker now towards the right hip, and here's what you see. Sort of a round, donut-shaped LV, base of the papillaries, nice round-shaped interventricular septum right there. That's a normal-looking peristernal short. It can also give you some information about ejection fraction, and that one's squeezing good. Apical four-chamber. So apical four-chamber is, if you only had like one view of the heart to get, that would be the view that you'd want to get. But the caveat is it's oftentimes the most technically difficult one to obtain. This view gets you a great view of the LV right here. So you can get LV systolic function. You see the RV right here. You can see how good the RV is squeezing. And you can see the LV to RV ratio, which is really important when you're thinking about PE patients. You can also see signs of tamponade from this view. Fantastic view. So once again, LV, LA, mitral valve, RV, RA, tricuspid valve. If you start to see the aortic valve flow tract in the shot, sort of like lift the probe up a little bit, and you'll see that the valves, the tricuspid and mitral, come back into the shot. If you see the aortic valve in the shot, that's technically an apical 5-chamber view, and that's not really what you want from this specific view. So probe marker towards the right. This is at the PMI, is where you want to put the probe. And most of my patients who are what I call Tennessee mediums, which is like 100 kilograms. So like one Tennessee unit is like 100 kilograms. And most of my patients are like 1 to 1.5 Tennessee units. And so when you feel nothing. You can't feel anything. So basically go just medial to the nipple, inframammary fold. And males have, in my state, inframammary fold as well. So that's usually what you go for. So probe marker towards the right, this is what you see. So it's a great view of the LV right here. RV, the LV is bigger than the RV. That's important. That's normal there. Got the mitral valve, tricuspid valve, LA, RA. And then subxiphoid. So this is the view that everyone is familiar with from trauma study. So just a subxiphoid process, lay the probe down on the belly, and this is the view that you get here. I'll show you subxiphoid, and really you need to lay the probe down on the belly and just push it down into the xiphoid process. Have the patient bend their knees can really improve your view here. And here's what you typically will see. So up here, you've got liver right here, and the first thing you come to here is the RV, which is the most anterior structure. Remember, the heart's sort of twisted, so the right side of the heart's actually more anterior than the left side. And so the first thing you come to is that the RV, RA, and this is the LV, and oftentimes you don't see the LA. Oftentimes you'll get the aortic outflow tract, and that's the aortic valve right there. That's a pretty classic subxiphoid view. That's really a good view to see effusion. It's kind of difficult and fraught with error to try to estimate ejection fraction on that subxiphoid view. You can, but you kind of have to fan through and kind of get a 3D sense of the heart. So it's most useful for a pericardial effusion. So that's the 4 basic views. So back to our cases. Remember, case 1, this is the lupus patient who came in feeling short of breath and weak and got hypotensive and altered. So I'm a year out from residency, and I go in there with echo. We have a Sonosite M Turbo. This is 2010. We got a Sonosite M Turbo, so I take that back there, take a look. And this is what I see. So what do you guys see there? What do you think? Pericardial effusion, hypotensive patient, tamponade. So this patient has very clear RV diastolic collapse. So a little bit of the RVOT right there. There's an effusion around the whole heart, which is this black right here. And you can see that effusion goes anterior to the descending aorta right here. That's clearly a pericardial effusion and not a pleural effusion. And you can see that the RV collapses right there. You see that sort of bump in right there when the valve is open. So they kind of go together like they're clapping. When that mitral valve opens, the anterior wall of the RV collapses in. So from an apical view, you can see this as well. It's important to sort of differentiate the left from the right side of the heart. When you see on the apical view, the RA actually is one of the first things that's affected. The RA actually bumps in during ventricular systole. So the RA bumps in, the IVC starts to get plethoric. That's one of the earliest signs of tamponade. And the next thing that happens is the RV gets affected, and that's when you really start to drop your MAP, and you start to drop your LV preload. So when the valves are closed, you get RA bumping in. When the valves are open, the RV actually bumps in. So you got RA bumping in, and then RV bumping in. You get a plethoric IVC. Those are sort of the 3 things you think of with tamponade. Once again, I just wanted to point out this is another effusion. This one does not look like tamponade to me. It can be subtle sometimes, but this looks like a pericardial effusion here because it goes anterior to that descending aorta. And here's an example actually of both a pericardial and a pleural effusion. If you guys can see that right there. So the descending aorta is the landmark you see right there. You've got a pericardial effusion right there and a pleural effusion posterior to that. The other thing is if you start to see one, you can't tell the difference. I like to go up to the left upper quadrant view and see if there's a pleural effusion over there, and that helps me sort of differentiate. But these can be really subtle sometimes. I will say that the management on these 2 patients is drastically different, right? So one needs a needle in their chest now if they're hypotensive. One may have a perineumotic effusion that doesn't necessarily have to come out right now, but obviously different managements in this patient. So your patient that's in front of you, there's this Venn diagram here of hypotension, pericardial effusion, and chronic disease, right? And chronic patients who have chronic disease have a lot of other reasons to be hypotensive. And so the question is, are they in that sort of area where there's clinical uncertainty, or do they truly have tamponade? And if you look at Beck's triad, only about 17% of patients have that. And all of my patients actually have muffled heart sounds. And so they automatically have 1 out of 3 right there. So not that useful. People say it's a clinical diagnosis. If I see somebody with pericardial effusion, the next thing I'm going to do is look at that IVC. If I'm thinking at all, this could be tamponade, because the IVC can help you rule out tamponade. So you get that subxiphoid view of the heart, and then lift up the probe, and you'll see the IVC. It kind of looks like a bunny, a specific bunny here, that will go unnamed. And then you twist the probe 90 degrees clockwise and put the probe marker towards the head, and this is what you see, sort of the long axis view of the IVC here. This is actually my IVC, and these are cholesterol crystals going back towards my heart right there. You can see that. Normally you can't see this, like you can see blood in a low flow state. You can see blood flowing through, but oftentimes you won't see that. And this is what it looks like when your patient does have tamponade. They have this huge plethoric IVC, which correlates to a high central venous pressure. So this is what tamponade would look like on an IVC. So greater than 2 centimeters, very little respiratory phasic change as the patient's breathing. And this is what it would look like if they didn't have tamponade. Can you guys see that? That's what we call the thirsty Gumby sign. See, looks like Gumby, right? And like you see that? He's thirsty. So that is a IVC that has a low CVP. So this rules out tamponade with about 97% sensitivity. So this is a patient that does not have tamponade. They got a pericardial effusion. They don't have tamponade. And here's a good example of a patient that's in tamponade. And actually, I want to show this because look at the RA there. See how it bumps in? You see it bumping in during ventricular systole, actually. And you see the heart swinging back and forth. This is a humongous effusion. This patient's had a chronic effusion. Very small amount of fluids can cause tamponade if they happen acutely. This patient has got a chronic one here. Just another example of a pericardial effusion here. Large pericardial effusion that goes anterior to that descending aorta there. So if you can't tell, the patient's really tachycardic, it's hard to tell when it happens. Is the RV bumping in during diastole, or are you just seeing the RV squeeze? It's kind of hard to tell. And so if you can actually slow it down. If you take a M-mode spike on a parasternal long axis and put it right through the RVOT and through the mitral valve, you can actually figure out when diastole happens and then look up there at the anterior RV wall and see when it bumps in. And that gives you information. That's actually a really good way to slow the heart down, and you have a great temporal resolution here. You can actually see when that RV collapses in there. And just remember that not all effusions are the classic sort of black. This is a patient that came in, I believe it was Jacob's patient. The aortic dissection? Yeah. Aortic dissection patient came in with this huge, isoechoic, pericardial effusion there. We call that the tongue of death right there. The RV is not even filling at all. Patient's clearly hypotensive, and I'm not even sure if you could probably, pull that out with a needle. The patient probably would have to have thoracotomy. Yeah, you tried? Yeah, didn't work, yeah, okay. And here's one that's probably chronic. This is sort of another atypical looking at chronic effusion with these septations through the pericardial effusion. And they can also develop tamponade. Even like a local one of those sort of loculated areas can actually tamponade, and these can be fairly complex. So what happens? So I go back to this holding area. I've never done a pericardial effusion in an awake, alive patient before. It's always in PA res as resident. And I grab a LP kit and put a needle at the largest pocket. It's actually sort of a parasternal long axis approach is where I was going, because that's the largest effusion pocket that I could get to. And as I pierce the pericardium, the lady screams out in pain. I'm like, oh, what am I doing? And it's all bloody. And I was like, I hope it didn't hit her coronary. But her pressure came up. She did fine. She actually went to get a window, and the ICU, she went to the CS ICU, and it ended up doing fine. Would I have been able to identify the cause of that patient's hypotension without bedside echo? I would say probably not. Would I have been so bold as to stick a needle in this lady's chest based off Beck's triad? Probably not. So, case 2. Remember, this is a 30-year-old kid who came in. He just smoked some weed. That's his only sin in his whole life. Doesn't really have any other medical problems. And he comes in looking really ill with bilateral interstitial pneumonia. It didn't make any sense to me. So we look at his heart. Right? That heart's really not doing much. It's just barely squeezing. And you can see that mitral slap is really poor. See, it's just barely opening. This patient has a very low ejection fraction. And this is what his lungs look like, all over. So this is very suggestive to me that this patient's in cardiogenic shock. So I have an I-stat troponin that comes back about the time that I'm getting this echo. His troponin's 35. And his EKG actually came back with ST elevations, clear ST elevations and reciprocal depressions. Again, no medical problems. So let's go through contractility, and I'll tell you how that case ended. So this is a great ejection fraction, right? I mean, the mitral slap is amazing. The LV squeeze is good. Look at that mitral slap. This is really, actually, maybe even almost hyperdynamic heart. This is a little bit of sort of mild to moderate CHF. You see there's a bigger distance there. The mitral valve isn't open as long, and the LV isn't squeezing as well. Can I teach you how to calculate the exact ejection fraction? Yes, but does it make a huge clinical difference if it's 35 versus 38%? No. You should be able to visually look at the ejection fraction and estimate it. And this is a patient who has severe CHF. So that mitral valve just barely opens up. Again, same thing, we're going to go to the apical view here. Good ejection fraction here. You can actually see the mitral slap here as well. So instead of looking at the anterior mitral leaflet, now we're looking at this one right here next to the septum. The mitral valve comes over and almost slaps that septum right there. Sort of mild CHF here, mild to moderate CHF. The LV is not squeezing quite as well. That mitral slap isn't quite as good. And then there's somebody with a dilated, ballooned out LV with a poor mitral slap. The mitral valve is only open for a very brief time during the cardiac cycle. So this patient has severe CHF. So what happened? So you got this ST elevation. I've got a patient with a troponin of 35. The first thing I do is, of course, talk to cardiology. Like, I think this guy, has myocarditis, but I can't tell. So they take him up to the cath lab, and he's got clean coronaries, ejection fraction 7%. He gets an aortic balloon pump placed in the cath lab, and he goes to the ICU. He actually ends up having a couple of VFib arrests from his dilated cardiomyopathy, but he was resuscitated just fine, and actually went to Vanderbilt, which is just a couple hours north of my shop, for heart transplant, because we don't do them at my hospital. So. But actually, he did not require a transplant. He was neuro intact, and he ended up bouncing back okay. We followed up because my resident was a friend of this guy's. And, not every patient that comes in hypotensive is going to do better with 2 liters of fluid. Like 30 cc's per kg on this guy probably would have killed him. It definitely would have put him into respiratory failure, and I would have been intubated that guy. And you push, 6-nocholine or rocuronium on a patient who has an ejection fraction of 7%, and you're probably going to kill him. And so probably 30 cc's per kg would have killed this guy. And if I give vancomycin, zosin's got a ton of salt in it. So that's not going to help somebody who's in cardiogenic shock. I'm not sure if I would have been able to diagnose this patient without bedside echo. Cardiogenic shock patients, they look poorly perfused, right? This guy's mucous membranes were cracked. I mean, he looked like somebody who looked dehydrated initially. All right, case 3. So again, this is the lady that keeps coding, who twisted her ankle. And we're all thinking, this is PE. This is PE. And we're thinking that, this patient probably could benefit from thrombolytics if it is a PE. And there's still that clinical uncertainty in your mind. Am I going to push thrombolytics on a patient I'm not 100% certain of? But bedside echo gives you just like that extra piece of information. And here's what her bedside echo looks like. So on this peripheral long axis view, you can see the LV looks hyperdynamic, and the RVOT just looks a little generous here. You see that? It starts sort of fan through. It really is pretty good sized. There's not much squeeze of that anterior RV wall. It's a little more dramatic when you switch to the peripheral short axis view. You can see the septum flattens out there. You see that? So she's got a D-shaped LV, high right-sided pressures. And our apical view here, LV small and hyperdynamic, RV big, RV free wall is doing nothing, and you have a little wink right there at the apex. That's a McConnell sign. Not 100% specific for sure. There are a lot of patients who have chronic RV dilation, chronic RV failure from things like COPD, chronic hypoxia, who have McConnell signs. Somewhere around 25% of those patients actually do have that. But in this setting, this patient who is otherwise healthy, who had twisted her ankle the week before, suddenly short of breath, dilated RV, this is all I need. This patient has a massive PE. So when you have a massive PE, you get a big IVC. Your CVP goes up, your RV congests, and the pressures are really high. You get this bowing out of the RV free wall with very little squeeze, and you get that sort of septal wink, and that's the McConnell sign. Now, most PEs, 80%, at least in the States, we've done we do a ton of CTAs in the chest. So most PEs have a totally normal echo. So you're not going to rule out PE with an echo. But in this patient, we're ruling it in. So is it acute versus chronic? It's really tough to tell. There's no like 100% definitive thing that you can see on an echo that says it's acute versus chronic, unless you see a clot in transit. If you've got a big snake-like clot in the RV, you're like, okay, it's a clot. But it's tough to tell. And so it's a historical thing. The first thing I do is I see somebody, that's hypotensive and they got a big RV. I ask them, do they smoke? Do they have like clubbing of the fingers? Are they on oxygen at home? That sort of thing. I mean, there are other reasons patients could have pulmonary hypertension, but that's one thing that can help me sort of differentiate between those two. And it's really about a history thing and put it within the clinical context. So what happened? So we did it. We pushed 100 milligrams of TPA on this lady over about 2 minutes. And she did not code again. And on the vent, she went from being blue to pink in 10 minutes. And an hour later, she was following commands. And a week later, she was discharged from the hospital, 100% neuro intact, to her teenage kids. If I had coded her 4 or 5 more times and then pushed thrombolytics, she may have gotten horrible pulmonary hemorrhage and died. You guys have seen that before. If you're going to pull the trigger on thrombolytics in a code, it's better to do it early. And this is the extra piece of information that got me to say, okay, let's do it. I can't even get this lady to CT. There's no way she would have made it to CTA. I'm convinced that bedside echo saved all 3 of these patients' lives. One got a needle in their chest. One didn't get fluids, ended up going up for heart transplant. And one ended up getting thrombolytics. So have I mentioned any literature today? No, but what I'm telling you is that bedside echo, if you become facile at bedside echo, you will save a life about once a month. So echo saves lives. That's all I got. That's sort of my finishing statement. Thanks, guys.
Okay.